Welcome to the Athletes Performance Podcast, where two performance-minded physical therapists break down the evidence to improve overall health, movement, and performance for athletes and active individuals.
All right, so episode 2 of the Athletes First Performance Podcast. How's it going, James?
Pretty good, Josh. We are getting some nice weather finally in North Dakota. It should be around 60 degrees today and this weekend, so hopefully going to be outside.
Yeah, I'm kind of experiencing the Midwest myself. Just moved to Minneapolis a week ago and kind of coming in with good weather, actually. So let's go ahead and get into it. Today, we're going to be talking about early stage, both preoperatively and postoperatively ACL reconstruction. And we'll sort of base this podcast off sort of a mini case, talking about an athlete that comes in post ACL tear a few days ago. They have not had surgery yet. And James, let's go ahead and get into what you would do on their first visit as far as education and objective measurements for that patient.
Yeah, so first thing in terms of education, you want to get a sense of where they're coming from. So you want to understand what sports they play, what year they are in school, and what their goals are in terms of getting back to specific sports or even playing in the future in terms of college. So getting a good understanding of that is the most important thing up front. And then objectively, there's a look for in terms of getting a quiet knee. So the first thing is getting full extension as early as possible. So some ways that we can do that are with like a knee extension heel prop. So propping their heel up on a foam roller or a towel and getting low load, long duration stretches to get that full extension. I prefer that over a prone hang just because it's a little bit more comfortable and they're not getting that hamstring co-contraction to get them to be able to just relax with that heel prop. The next thing we want to look for is at least 120 degrees of knee flexion. So we know that before surgery, we want good range of motion to allow for better range of motion after surgery. So at a minimum of 120 degrees is what we're looking for. And there's multiple ways that you can do that. You can do that starting with like supine heel slides, wall slides, and eventually once they get around that 110 degrees of range of motion, you can use a bike to help improve just overall knee mobility and stiffness. The next thing that we're going to look for is quad control. So depending on how much swelling and pain they have, they might not even be able to perform a quad set. So the first things that we're doing, day one, are looking at that quad set and straight leg raise to see if they have any type of quad lag. And if they do, probably starting with some neuromuscular electrical stim just to get that quadriceps muscle going. And we'll talk about NMES a little bit later in the podcast in terms of specifics. I also want to take a look at measuring swelling. So that's something that we can objectively measure before surgery and after surgery to get a good sense of how well they're managing exercises and day-to-day walking and moving around. So some ways that I can measure it is like using a tape measure in centimeters going mid-patella, and then that's going to be like knee joint effusion. And then you can also look at quad size or quad girth, because if they're coming in a couple of days right after their injury, they're not going to have a huge amount of atrophy. So getting that baseline quad size is going to be important for after surgery. So some landmarks that I like are about 2 inches above mid-patella, 6 inches above mid-patella, and then 6 inches below mid-patella. So you're getting a little bit of the calf and quad, again, just to get that baseline for after surgery. And then depending on who they've seen before they came to you, they might not even have crutches. So you want to go through gait training, get them, if they're limping without crutches, then you definitely want to give them crutches, be able to normalize their gait pattern and take some stress off their knee. And then as they keep on getting stronger and getting better range of motion, you can gradually progress them off the crutches. So those are my main treatments for getting that quiet knee. There's also some things that we can help in between sessions. So I'll probably give them some type of compression sleeve to wrap around their knee to help manage swelling, as well as depending on what resources you have. So if you have a game ready in the clinic, that's great for cooling down the knee, decreasing pain, and then also that pneumatic pump decreases swelling. And then if you've seen Normatechs, or if you have a Normatech in the clinic or the gym that you're a part of, getting them in the Normatech after the session for 10, 15 minutes is another good way just to pump that swelling out of their leg. And then of course, like we do after surgery, using the muscle pump, like quad sets and ankle pumps with elevation, are great ways that they can help manage swelling after any type of injury at home or in the clinic.
After they have achieved that criteria for having a quiet knee, what are some other things that we can do pre-operatively to set these athletes up for success after surgery?
Yeah, so I guess what you have to look for are the two different types of patients and determine which category that person's going to fall in. So we have copers and non-copers. Officially, copers are defined as athletes who maintain their dynamic stability after their injury, whereas non-copers are athletes who continue to have instability in spite of rehab. There's a battery of tests that you can do to determine if someone is a coper or not. Those would include the time 6-minute hop test, the knee outcome survey, the global rating score, and you want less or equal to 1 episode of giving way since their injury. Um, we have studies that show there is exercises that you can perform that can actually move someone who tested out as a non-coper into a coper. And ideally, if someone wants to continue their sport without having to have surgery, based on the timing of the season they're in, based on what their goals for, let's say they're a high school athlete that wants to play in college, and they have that ability to do some prehab per se, and then push off the surgery until later. If they do test out as a coper, they're going to have a lot better shot at continuing to perform the sport before they have surgery. So when you look at a coper, regardless if they have surgery or don't, they're going to have a way better odds to succeed at a 2-year follow-up compared to those who are non-copers. I think the stat was like 2 to 3 times the odds to succeed at a 2-year follow-up. And the biggest thing that we found with looking at copers versus non-copers, is that with performing a 10-session exercise routine that I can detail a little bit, but we'll add it in the show notes, they're able to move 45% of non-copers to copers. So if we talk about what we want to do beyond getting that quiet knee, if they have the time and they have the ability to perform more exercise before they have surgery, you can look into doing some aerobic work on the bike, a lot of strengthening, whether it's single leg squats, step ups, hamstring, quad work, a little bit of plyometrics in the sense of a lateral hop or a skater bound, and then working on neuromuscular training just to try to give them a little bit more control. And the progression there would be going from single leg stance, anterior posterior, to medial lateral, to diagonal, and then just basically working back to sport specific. It's interesting because those patients that, when compared to a group that didn't do any sort of prehab per surgery, they had significantly higher return to sports rates. They had significantly higher subjective reports of function. And this was all at a 2-year follow-up. So it was changes that lasted. And like I said before, having that program be able to move non-copers into a coper situation, and then they're able to maintain that coper status, that's huge. Whereas I think in my experience, I don't really have the time to be able to give someone that exercise program, particularly for the length of time that they were doing it, which was 10 sessions. But it's just something to be aware of. If you do have the time, it can be really important in getting the patient to extend their time playing pre-surgery. It can prevent them from having to have surgery. And even still, if they're going to go have surgery, it can give them better outcomes in the long run. So beyond that, James, what other tests or measures would you do if they're able to before surgery, just to get you a baseline on what to expect after surgery?
Yeah, this is a really good time to get those baseline measurements because they haven't had enough time to get that major disuse atrophy. So we know that after 9 to 12 months of rehab, their non-involved or uninvolved leg is going to be a lot weaker than it was before surgery in the most part. So getting that good baseline measurement of their uninvolved limb as well as their involved limb prior to surgery is going to give you a little bit better landmark in terms of what you want to get to after surgery and for return to play. So some good baseline measurements that we can take, as long as you have the equipment, are quad and hamstring strength. So using something like isokinetic machine, a handheld dynamometer, or something that I've been using over the past probably 4 months is a Tindeck device. And we can go into a little bit of that later, or we can put that in the show notes or Instagram. But just being able to measure quad and or knee torque in terms of knee extension, knee flexion is going to be huge. We can also look at things like the wide balance test because we know that there's certain markers that we want to achieve prior to return to play. And then some other exercises or measurements that don't require a lot of equipment would be like a single leg squat test. So in terms of testing overall single leg endurance would be max reps of a single leg squat. Then you can also do like a 5 times single leg squat 4 times. So you're assessing endurance for the first one and then power for the second one. If you have access to a leg press, you can do a 10 RM of a single leg press to assess for strength. And then depending on where this athlete is, you can also assess a single leg hop, the triple hop, and just like you mentioned, that 6-meter time hop. And if you have the app on your phone, like the MyJump app, you can also assess single leg vertical hop. So those are all great measurements that you can get pre-surgery to help give you a standard of what you want to achieve prior to return to sport or return to play.
What time would you do these tests? So are you going to do these tests? Let's say you don't have the luxury of doing that 10 session or however long session of further strengthening that was talked about in that COPR, non-COPR study. Are you just going to do these like the patient saying, all right, I'm having surgery next week. I'm going to just try to run them through as many tests or whatever tests they can tolerate? Or are you going to do these earlier on in the prehab phase? When would you do them? Or ideally, when would you do them?
Question. So it all depends on the timing. So if they're having surgery next week and this is their first session, I might try to get as many objective measures on their uninvolved leg as possible. So if they can't hop or if they can't do single leg press on their involved leg, I might just run through all these things on their uninvolved leg, again, just to get that baseline and see what we need to get to after surgery. But if we're able to go through that 10 session or 5-week neuromuscular strength program,
and they're able to develop into a COPR, we should be able to get some of their single leg hop performance measures or single leg press, wide balance, or leg extension strength to be able to determine where they need to get to after surgery.
When we talk about post-surgery, let's say the athlete's coming in for their first visit after having surgery. A lot of times, in my experience, I won't see them until like 4 weeks post, but that's just the doctors that I've worked with. I know you've been working with more higher level athletes. You'll probably see them sooner. So let's just talk within that first 0 to 2 weeks, that phase. When we look at protocols, what type of protocol do you tend to lean towards? And there's 1,000 of them, but just in general, we have mainly time-based protocols and we have criterion-based protocols. And I think in my experience, Adrian Peterson kind of ruined the time-based protocol with him being able to come back from ACL surgery in 6 months. So which one do you lean on?
That's a good point. Adrian Peterson is a genetic freak. So most of our high school kids aren't going to be the genetic freaks like Adrian Peterson. So there's been a big shift more towards that criterion-based protocol. We still have to respect biology and healing times along with the specific surgeon's protocol. You have to respect what the surgeon wants and what they send you, but you also can go based off your clinical reasoning and clinical judgment with the patient in front of you.
So what are you going to do for that first visit and then just generally that first 2 weeks post-surgery with that patient?
Yeah, so from most of my experience working with these athletes, I usually see them anywhere between 1 and 3 days post-op, and they're coming in with their crutches. They may or may not be putting weight down on their foot, and they've got their bandages and their ACE wrap on. So the first thing that we do, hopefully you've worked with them pre-op, so they're a little bit more familiar with you and they're pretty comfortable with you and they've known what to expect. So we're just knocking that off right off the bat. But the first thing that we do, we get them on the table, we take that ACE wrap off, we take off the bandages, make sure the patient's comfortable looking at their knee because there might be a little bit of blood and swelling and some nasty stuff under there. So just get them comfortable with that. And then in the clinics that I've worked in, we pretty much take some gauze pads and alcohol wipes and just clean off their leg, get them more comfortable because they haven't showered since surgery. So cleaning their leg off and making sure that all the steri strips are in place. All right. So after the wound care, we're going to get right into that range of motion. So as we talked about earlier, the most important thing early on after ACL reconstruction is achieving full knee extension. So the way that I've done it most successfully is doing those heel props. So putting their heel up on a towel or a foam roll and using their handheld pressure to push their knee down, or like a stretch strap just to pull their toes towards their nose and just get those low load, long duration holds. In terms of knee flexion, we want to be a little bit more careful with that. Their knee's going to be swollen, painful. They're still going to have their stitches in place. So just going with a knee flexion range of motion to tolerance. So depending on how comfortable they are, if they're able to move their leg with their nerve block, we might be doing passive range of motion with them sitting off the edge of the bed, just the tolerance, or we might be doing some things like wall slides or heel slides. The next thing that we're going to do is just work on a little bit of patellar mobility. So again, they might be a little bit apprehensive in terms of their knee just being fragile. So teaching them how to perform patellar mobility gets them a little bit more comfortable just touching their knee, moving their knee around, and helps decrease pain a little bit as well.
And one of the ways that I like to start regaining quad control is with the use of NMES. So I'll start at 0 degrees of knee extension with quad sets and 4-way straight leg raises, and then progress to isometrics at 60 and 90 degrees of knee flexion as the range of motion continues to improve. And there was a recent systematic review published in Sports Health to help find the best parameters for NMES after knee surgery. And the biggest thing that they found was making sure that you're working at an intensity high enough to produce a visible quad contraction in the athlete's knee. So early on, it might be a little bit more uncomfortable for the athlete, especially if they've never had NMES. But during the session, you want to continue to increase that intensity. And every follow-up session, you want to continue to increase the intensity to make sure that you're getting as much quad contraction as possible during the different exercises that you're using. So once they hit the 2-week mark and they get their stitches out, I'll start incorporating BFR with their quad sets, 4-way straight leg raises, and progressing to things like prone, sitting, or standing TKEs. At the 4-week mark, as long as everything is going well, I'll start incorporating BFR with a leg press or shuttle press, and even open up the open kinetic chain knee extension like long arc quads 90 to 40 degrees, starting with no weight and then gradually progressing with weight and increasing range of motion as tolerated.
We're also doing a little bit of gait training. So depending on the surgeon's protocol and depending if they're using a brace or not, we're going to start with that. So from my experience, for the first 2 weeks, the surgeons prefer them to be locked in knee extension with a T-scope brace, and then weight bearing is tolerated. So we're just going to get them on the ground, getting them comfortable, putting their foot on the ground, walking with the proper gait pattern, using their crutches and their knee extension brace. And then the goal, again, is to get that quiet knee in the first 2 weeks, like we talked about earlier. So I know the big thing in the literature right now is open versus closed kinetic chain. And Josh, why don't you take us through what we're seeing in the literature in terms of that big debate?
Yeah, so this was one of my favorite parts to look at because I remember in PT school, it was just nailed into our heads that we shouldn't do any open kinetic chain with people that have had ACL reconstructions, to the point where when I had my first ACL reconstruction patient, I don't know, in the residency, I guess, so my first year out, and I was afraid for them to even move their leg without being able to completely lock it out into a full quad set without any lag. Just picturing the ACL just shredding like toilet paper. I know that, so a lot of that's changed at this point, and I know I was being way overcautious like any first year PT would do. But yeah, so we know that the quad is super important when it comes to ACL recovery, function, and return to sport. The muscle is going to be inhibited, whether it's neurologically or, like you said, because of pain or swelling or the nerve block early on in ACL reconstruction rehab. And there's really only one way to be able to get that inhibition to return, and that's going to be through isolating the muscle. And the only way you can really isolate the muscle is open kinetic chain, and that's going to be with open kinetic chain knee extension. A lot of times, and previously in the research, closed kinetic chain was the primary treatment early on for strengthening. But there's just so many opportunities for compensations to avoid using the quad, so you're not going to get that same isolation that's needed to improve or restore the quad function. So there's a really good study that came out back in 2012 that looked at the strain on the ACL with certain open kinetic chain and closed kinetic chain exercises, and also looked at the strain on the ACL with functional activities like stair climbing and walking, etc. So what they found in general was that the primary strain, or the majority of the strain on the ACL, occurs in minimal levels of knee flexion. So between 10 and 30 degrees of knee flexion, and that's both in closed kinetic chain and open kinetic chain. They also found that dynamic knee extension, or a long arc quad, will load the ACL less than level ground walking. So if we have a patient walking, which is one of the goals, with no gait abnormalities early on after ACL reconstruction, then they should be safe to do dynamic knee extension. Now, for what they found was the highest load on the ACL occurred during either an isometric knee extension or with isokinetic knee extension, particularly in those lower levels of knee flexion range of motion. And when they compared all that data on open kinetic chain exercises to the closed kinetic chain exercises, there was really no difference between squats, single leg squats, stair climbing, leg press. So all of those exercises that we like to start out with in closed kinetic chain early on in rehab load the ACL similarly to an open kinetic chain knee extension. So that tells me that it's important to include those exercises with your closed kinetic chain to help restore the quad as quickly as possible. There was also a systematic review that came out in 2012 that looked at the anterior knee laxity, so basically ACL loosening, with protocols that started with open kinetic chain exercises early, which would be 6 weeks and earlier, versus started with those exercises later, beyond 6 weeks, and in those protocols that just did closed kinetic chain. And there was no difference in ACL laxity with any of those protocols. The research was deemed to be low to moderate research or evidence that there was no difference in ACL laxity between protocols. So there is caution that should be taken just because the research isn't what we would say high quality, at least at that point. But regardless, I think they're safe to do. So if we look at what arc of strain or what arc of range of motion where strain is the highest, we already said it's 10 to 30 degrees of flexion. As you get closer to 60 degrees of knee flexion, the strain gradually decreases to the point where if you're greater than 60 degrees knee flexion, there's no strain on the ACL with open kinetic chain. And that also goes with closed kinetic chain. The strain gets lower as you get into higher levels of knee flexion. The issue is that they may not have that range of motion yet, or they may have too much pain, whether it's patellofemoral discomfort. If they had a bone patellar bone graft, that could be uncomfortable, to where those deeper levels of knee flexion aren't comfortable yet. So you have to be careful with that. But if they have the ability to get into bigger levels of knee flexion, then loading the knee in that position can be very helpful to help restore quad function as quickly as possible. So as far as the progression that I would start with a recent ACL reconstruction, and this is 2 to 4 weeks post rehab or post reconstruction, in regards to open kinetic chain knee extension, I would start with a partial arc. So between 90 and 45 degrees of from knee flexion to knee extension, and then progressing that to a full arc by 8 weeks. Now that would be with a soft tissue fixation or a hamstring graft. You could probably go a little bit quicker with a bone patellar bone graft just because it heals a little bit faster. But essentially, you're just gradually progressing to the point where they can go from 90 degrees to 0 degrees of knee extension in order to get that quad strength back as quickly as possible. When you look at closed kinetic chain exercises, you don't really have to be too concerned with ACL laxity because the loads on the ACL are pretty small. But if you are trying to prevent load, let's say the patient's early on after rehab, they can achieve deeper knee flexion angles where it's safer to do some of these exercises. You can play around with trunk lean or the angle of the tibia in relation to the floor or how far the knee goes over the toes. So the farther the knees go over the toes, you're going to have more strain on the ACL. They say that's because as the quad contracts, it's pulling the tibia anteriorly. As you push the knees over the toes, it's going to be more of a quad dominant exercise. So theoretically, you're going to load that ACL more. If you keep a more vertical tibia angle, you're going to have less load on the ACL in one regard because you're not pushing the knees forward. But on the other regard, when you keep your tibia angle more vertical, it'll depend on what your trunk's doing to decide if you're loading it more or not. So if you're keeping your trunk more vertical and your tibia angle more vertical, you could possibly create more ACL loading just because the quad's going to be recruited more with a more vertical trunk. If you pitch the trunk forward, as you can kind of just picture a deadlift almost, or progressing towards that position, you're going to recruit more hamstring, and that's going to help create a posterior force on the tibia, which will help unload the ACL. So the research shows that open kinetic chain knee extension is safe. I think you'll get a better understanding of what you can and can't do if you look at that article that looks at the ACL strain with different activities. But in general, personally, I would start doing open kinetic chain, but I wouldn't just go from 0 to 90 right away. I'd start in the greater knee flexion angles and then progress to that last 30 degrees to 0 degrees as the patient gets farther out from their surgery. Do you have anything else you'd like to put on with that?
Yeah, so another adjunct would be using blood flow restriction training. So using BFR, you're still getting that metabolic load with the quadriceps, but you're not having to use a whole bunch of weight, especially that distal weight that will increase a little bit more strain on the ACL. So BFR is another great tool that you can use early on to help unload the knee, but still build strength in your quads or whatever muscle that you're working on.
After the patient is now 2 weeks post-surgery, they're coming into the clinic, they have their quiet knee, you started to work on quad strengthening in a comfortable manner, let's say in a lower arc, or you're planning to start that soon. How would you go into phase 3? We'll call that 2 to 6 weeks post-rehab. What would you be looking at and what type of treatment would you be doing?
Yeah, so everyone's favorite question early on is, when can I start walking? So that's going to be one of the first things that we start working on. And I like to give them a few landmarks or criteria for them to be able to start walking without their crutches. So usually, like I said, that first 2 weeks they're using their crutches, weight bearing as tolerated in the brace. But then at that 2 to 4 week mark, depending on how well they're doing, we're starting to introduce walking without the crutches. So the criteria that I use to get rid of the crutches or discharge the crutches are full active knee extension range of motion and no pain on passive overpressure. So like we talked about in that full knee extension, and then giving them that good control in that full knee extension. So we want a good quad contraction with a superior patellar glide. And I like to have them be able to do 20 straight leg raises in a row without an extension lag. So that just shows they have that good quad control and they have good enough endurance to maintain that quad control. Then they also need to be able to walk pain-free without any compensation. So we're looking to gradually improve that knee flexion range of motion, trying to get past that 120 mark. We can go through the heel slides, the low load, long duration stretching into extension. We're probably at the point where we're starting to bike a little bit once they get past that 100, 110 degrees of knee flexion. And then we're getting into functional standing exercises. So we're doing some type of squats. They can do mini squats holding on to a TRX or wall squats, small step ups, getting into a leg press, starting with 2 legs and gradually progressing down to 1. And then depending on what type of graft they had, starting a little bit more posterior chain exercise like hamstring curls, or starting to get into that hip hinge motion. So in terms of a hamstring graft, we probably want to be a little bit more careful activating the hamstrings or strengthening the hamstrings the first 6 to 8 weeks. But if they're a bone patellar bone graft, we can get the hamstrings going pretty quickly. And then in terms of just getting comfortable with the weight bearing, outside the squats and the step ups, we can get their calves going. So standing heel raises, progressing from double leg to single leg. And then, like we talked about in that prehab neuromuscular training, we can get them on a wobble board or a rocker board. Again, just getting them comfortable with weight shifting and putting equal pressure on their involved limb. Is there anything else that you want to add to that?
No, I guess the biggest things that, and if I had to summarize as far as the big things that I look at and the issues that I've had with patients post ACLR is if they don't have pain, they typically go pretty well, at least in my experience. Most of the patients that come in and they're very painful, and I had one example that I got to do prehab with, because they were going to see if she was going to be able to return to just ADLs without having surgery. She wasn't a high level athlete or anything, but I had that time with her, which is, rare and kind of a treat, I guess you could say, to be able to work with her, educate, and give her exercises. But regardless, she still came in post-op with high levels of pain that just didn't resolve for probably the first 6 to 8 weeks or so. And that just set everything back because she couldn't tolerate any sort of extension stretching with overpressure, which means she couldn't get terminal knee extension, which means her quad wouldn't fire as it should, because she was constantly having a quad lag. So when pain's in the equation, it just throws everything off. And you can do stim and ice and different things to help control that. But I think the emphasis on getting a quiet knee as fast as possible when you can is so important because, like I said, pain's going to not allow stretching, whether it's flexion or extension. Pain's going to inhibit the quad. If you can't work the quad, you won't have that benefit of a muscle pump to get the swelling out, which can also inhibit the quad. And then you start to get stiffening. And it just kind of it spirals downhill from that point. So for me, if we can control pain, control it as best you can, and then hammer knee extension so that you can get terminal knee extension, which will then help the quad perform like it does. And once you get past that stage, if you can hit those parameters of full knee extension, minimal pain, minimal swelling, I tend to find that it goes pretty smoothly, at least up until the point where you get into higher level activities. Because for the patient I was talking about, for example, because she started off with so much pain, that just created that cascade of events to where she got pretty far behind. And when you start to get into those closed kinetic chain exercises, because she's not working with a strong quad, I mean, you can put her in positions to try to force quad use, but she learned how to compensate right away. And then once you do that, you're really never loading the quads unless you isolate it. So any sort of anterior knee discomfort, patellofemoral discomfort, really throws off, I think, the rehab from the beginning. So trying to get that knee as quiet as possible with minimal pain is super important. Do you have any special tips or any things that you would do if the pain was the primary limiting factor post-surgery?
So there's new research coming out with blood flow restriction training that alters pain. So just like isometrics help modify pain response in like a tendinopathy, like patellar tendinopathy, for that 40-45 minutes, there's new research out from Luke Hughes showing that using blood flow restriction training can also be more of like an analgesic effect for that 40-45 minutes. So for the athletes that I've used BFR on, that's usually the first thing that we do in the session. You stretch them out a little bit, and then BFR with NMES for quad sets, leg raises, like 4-way straight leg raises. And that thing hurts so bad it blocks the pain. So they're able to get through it, and by the time they're done, they don't have that same anterior knee pain because they just worked their butt off going through BFR with that tourniquet on. So that's something that I've found that's really good early on to help modify and block some of that pain. And then also, like we talked about, NMES, a lot of the research is showing there's no long-term benefits of NMES, but using the NMES the first 2 weeks sets them up for a better quad contraction and better quad control, which again can help decrease their pain later on as they start loading their joint a little bit more. And then, of course, using any type of cryotherapy, game ready, Normatec, just to help cool down the knee, get the swelling out of there, are also things that I like to use. Yeah, I can't really think of anything else outside of that. I don't really do too much manual therapy. I've seen a lot of people do like ASTIM or instrument assisted soft tissue work right after ACL reconstruction, and I don't know, just not a fan of that. So get your patellar mobs going, get any type of manual therapy in terms of joint mobs going, nice and easy just to modify pain. But other than that, I don't really have anything else.
Yeah. Hopefully that that would take care of it, and it does obviously depend on the person. Pain is widely individual, and I would tend to see the more active population or probably be able to deal with that a little bit better. I want to touch on another topic that I find interesting, and maybe you have some ideas about it too. But when we talk about someone who gets behind in quad strength, and then they move to the open kinetic chain exercises and start to learn how to compensate, that can become a real problem. So it's interesting in a lot of the protocols where they want you, more of the, I guess, older protocols that was avoiding open kinetic chain quad exercises, those primarily pointed to doing closed kinetic chain early. But if the quad isn't where it needs to be, then you could be at the same time going ahead and putting them in a situation where they can learn to compensate. And it's way harder for me to get someone to stop compensating than to try to put them in the situation where they won't have to before you start some of those close kinetic chain exercises. Obviously, you can play around with the position. You can avoid larger knee angles if they can't control those positions, which they might start to compensate at that point. And it's pretty obvious when you see someone compensating with a bilateral exercise by using the uninvolved limb. But when you start to get someone into what looks like a pretty symmetrical squat, or they're starting to do single leg activities and it looks pretty good, but you test their quad strength with a dynamometer or however you'd want to test it, and it's still checking out as weak, you have to be concerned that they're doing some intralimb compensations. And this is just coming from past experience with me personally with some knee issues. Like, it's really easy to be able to knock out some single leg exercises, but avoid the quad, whenever you can. So is there anything that you would do, I guess, outside of some common force use on the quad, which would be like a staggered stance squat, or things like that? Is there anything else you would do to help either prevent or try to train out of compensations that someone might pick up?
Yeah, so I think the best way to do that is try to put them in a position to succeed right away. So like you were saying, if you start those closed kinetic chain exercises like squats too early and they don't have a quad, you're just training bad habits. So some of the criteria that I've seen in different papers are having at least 50% quad index, because then that they're able to handle 50%, their quads working at least 50%, they can handle 50% of their body weight on two legs. Another thing that I've seen is being able to single leg press at least 50% of your weight. Again, being able to manage half your load on that leg. So we know that the leg press isn't as specific to the quads in terms of strength testing, but then at least that you're able to manage half of your body weight on that leg. So that's the biggest thing, just not allowing your patients to just continually load and load and load their squats early on if that they don't have a quad. So getting into the testing and assessing, there's some people that assess their knee extension torque on visit 2. I'm not doing that because I just don't have the the actual equipment to do that, but probably starting at weeks 4 or 6, depending on how they're doing, I'll just start assessing their knee extension torque with that Tyndall device, and just being able to determine where they are will help me better guide my exercise prescription. So if they don't have a quad, or they don't have quad strength, they're staying with that BFR just to get that muscle strength and hypertrophy. And then once they get to that 50%, then we'll start getting a little bit more into their squats. But in terms of loading the quads a little bit more, some things that I've used are like squatting with the heels elevated, so getting them on like a slant board or plates, being able to do like goblet squats with the heels elevated, tempo squat, so slow on the way down, 1 second pause, slow on the way up, just getting that more time under tension, and then helping them get better symmetry on their right versus left leg. So those are the things that I like to use early on.
Yeah, no, all those make sense. And this kind of leads me to another question that just could be interesting to see what you think. If we kind of take out the isokinetic machine just based on the price, what are some, if you could build your own clinic around ACL reconstruction rehab, what are some of the main equipment pieces that you would like to use to help improve their strength, range of motion, whatever it is? What type of things would you like to have in that clinic?
So one thing that I don't have right now is a knee extension machine. So 3 years ago, if you asked me if I would use that, I would say no. But just looking more into the research and seeing what everyone's pointing out about how important the quad is and isolated quad strength, I would definitely use a knee extension machine. And once able, start loading eccentric quad strength, because that's another thing that we haven't really talked about. Using eccentrics early on is one of the most important things you can do to build that quad strength, because that's going to override the central nervous system and allow better strength and hypertrophy of the quad. So like a knee extension going up with 2, down on 1, or if they're sitting in a knee extension machine, you help them get up with one leg and then they slowly lower it with their same leg. Definitely like a leg press or a shuttle, like a squat rack. Squat rack is almost mandatory in PT clinics in my eyes. So being able to use different squats, front squats, back squats, trap bar, goblet squats, all of those, but just making sure that they're able to adequately have the right amount of strength prior to going unrestricted in any type of bilateral knee dominant exercise. What about you? What are your thoughts on that?
Yeah, during that quad torque, you really need something that you can load up in the extension. And I haven't found, you can stack 1,000 ankle weights onto their leg, but eventually that becomes ridiculous. I've tried to use some of those Rogue stretch out bears, jump stretch bands, to create almost like a cable knee extension, but your resistance is just going to vary as you get farther into the movement. So I would say leg press, knee extension machine, and then some sort of box. You could use a low table or a I guess a big step or something like that, to where you can work on some single leg step ups, step downs, drop jumps, and things like that, or box jumps. So those would be my main 3. I guess
those are
say.
all good. And then BFR, I love BFR early on. It helps the athlete feel like they're actually going through a workout, in those early phases. So it makes them feel like an athlete again, and all of those other things that we talked about in terms of pain, decreasing pain, improving muscle strength and hypertrophy. So any type of BFR would be awesome to continue to have in the clinic.
Yeah, I know you're the BFR guy, so that makes sense. And I like it too, not to make fun, I guess. So we're gonna finish with that. We'll get into phase 3 rehab later on. Once the patient has full range of motion, minimal swelling and pain, and they have good strength and control in daily activities, they'll start to progress that direction. But that will be for part 2 of ACL rehab after reconstruction. James, is there any resources that you could recommend people to look at for more ACL information?
Yeah, so anything from Lynn Snyder and Macklin she's the ACL queen. So she's out of the University of Delaware, and she puts out a whole bunch of different research articles and papers regarding ACL return to play, ACL criterion-based protocols, running protocols. So she would definitely be one of them, as well as anything from like Lenny Macrina on social media. He does a lot of clinical research as well as putting out things on Instagram. So he puts out a lot of good information on Instagram that you can go follow. Nothing else coming off the top of my head there. Anything for you?
Yeah, for sure. So my number one go-to for ACL information and just practical advice that you can use in the clinic is Eric Mira. His website, the Science PT, has a lot of good blogs and things like that, particularly focus around trying to get the quad back. I also there's an Instagram page by Wesley Wang. He puts out a lot of really good exercises and treatment strategies on ACL rehab based on the phase that they're in. So that's a really good resource if you're running out of ideas or need some ideas for treatment. And then Tim Hewitt has some good stuff also. So yeah, those would be the three that I would use, but particular emphasis on Eric Mira's stuff.
Yeah, so
right,
thanks to everyone for listening to the podcast. All of our resources will be listed in the show notes and on our website. So we're going to try to put out a podcast every 2 weeks. So be sure to look forward to our next one that will focus on why we chose to do a residency and what it was like for studying for the OCS or the SES.
Thanks for listening to the Athletes Performance Podcast. If you have any questions regarding this episode or future episodes, please be sure to reach out on social media or our website.